Hi, this is Shauna Gunaratney, and let's talk about TB treatment in special populations. So, in regards to treatment of TB in pregnancy, isoniazid, rifampin, and ethambutol are all thought to be safe in pregnancy. There's less data on safety with pyrazinamide in pregnancy, and this is recommended to be used in a case-by-case basis within the United States. Again, if pyrazinamide is not used as part of the regimen for treatment of TB, the regimen needs to be extended to 9 months. The WHO, however, recommends using isoniazid plus rifampin plus ethambutol plus pyrazinamide in pregnancy, especially in areas where endemicity of TB is higher. There's no change to any regimen for those who are breastfeeding or lactating. And because people who are pregnant are at higher risk of neurotoxicity from INH, it's recommended to give pyridoxine or vitamin B6 in addition. Pediatric TB is notable as it is more difficult to diagnose because children have paucibacillary disease and weaker cough reflexes, so often they might need a gastric aspirate to confirm the diagnosis. However, the treatment regimen is similar. We recommend 2 months of 4 drugs for the intensive phase, followed by 4 months of 2 drugs. Steroids can be used in TB and are actually recommended in CNS TB or TB meningitis due to a mortality benefit and should be used for the first 6 to 8 weeks of TB therapy with a taper. There's conflicting data in use of steroids with tuberculous pericarditis and is not quite known whether steroids should be used, and so these should be decided upon in a case-by-case basis. So let's talk about TB and HIV. So TB and HIV epidemiology, unfortunately, they are overlapping epidemics or syndemics. And you can see here that unfortunately, many countries, especially in sub-Saharan Africa, carry the burden of those living with TB and HIV. So you can see here in terms of overlapping epidemics, those countries who are colored in red, especially dark red, have high rates of HIV and TB co-infection. In terms of who is being newly diagnosed with HIV or TB, you can see again the darker red, so in particular South Africa. And again, the mortality, unfortunately, in those living with HIV and TB are carried by those living in sub-Saharan Africa, India, parts of Southeast Asia, as well as China and Russia. So important clinical points about TB and HIV. So those living with HIV diagnosed with TB have increased rates of mortality. TB is actually the leading cause of death worldwide in people living with HIV. Those who have HIV are more likely to develop active TB. They are more likely to have paucibacillary disease. So if you look at their sputa, they are often smear negative. They are less likely to have cavitary disease because they have a less robust immune response. It is not recommended to use intermittent therapy for treatment of TB in those living with HIV. Those who have HIV and latent TB infection have higher rates of reactivation, up to 10% per year, meaning that over 10 years, their risk of reactivation is 100%. And so those who are living with HIV would highly benefit from latent TB infection treatment and should be screened for latent TB infection and should be offered treatment as soon as possible. Special treatment considerations for those living with HIV. We do not recommend using intermittent TB regimens. Shorter TB regimens can be used, but with caution. We recommend starting antiretroviral therapy within 2 weeks of TB therapy, and for CNS TB, we typically delay antiretroviral therapy for 8 weeks. Unfortunately, there are a lot of drug-drug interactions between the medications used to treat TB and antiretroviral therapy. Rifampin is contraindicated with boosted protease inhibitors, so those patients need to be switched off PIs. Tenofovir alafenamide daily can be used with rifampin, but it's recommended to monitor the viral load closely when using TAF with rifampin. Rifampin decreases integrase inhibitor concentrations, including dolutegravir and bictegravir. Traditionally, we would recommend doubling the dose of dolutegravir if someone is on rifampin. Rifabutin has fewer drug-drug interactions, and so we don't need to double the integrase dose, specifically dolutegravir, when using it with rifabutin. There was a trial called the Radiant TB trial, which showed that dolutegravir once daily dosing was enough to achieve viral suppression, so may not have to double the dose, but most guidelines still suggest recommending doubling the dose of dolutegravir. 3-HP plus once daily dolutegravir is sufficient from the Dolphin 2 trial, and there was a trial called the INSIGHT trial that showed that twice daily tenofovir alafenamide, emtricitabine, and bictegravir, otherwise known as brand name Biktarvy, can achieve viral suppression when used with RIPE.